Welcome everyone to the June 4th, 2020 COVID-19 clinical care rounds focused on air and ground interfacility transfers. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 emergency department challenges and successes. If I'm a physician, nurse, or EMS clinician, transferring, transporting, or receiving large number of COVID-19 patients, the healthcare providers I want to learn from are those who have the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who have collaborated. These are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Next Monday, June 8th, will be EMS rounds focused on COVID-19 and protests. Next Tuesday, June 9th, will be critical care rounds on the ugly tail end of COVID-19 acute respiratory distress syndrome. Next Thursday, June 11, will be emergency department rounds focused on nursing perspectives of recovery and preparing for a second wave. It is self-evident that our nation's medical response challenges are changing every day while we are still trying to understand how to save lives of those with COVID-19 and understanding how to take care of ourselves as healthcare providers. We'll continue to work on identifying topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. For the ECHO clinical rounds, we continue to have participants from all states and multiple countries, predominantly physicians, nurses, and EMS clinicians. Thanks to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. These ECHO clinical rounds and NETEC's webinars are complementary to each other. Thanks to the American College of Emergency Physicians, the Emergency Nurses Association, in their support of these emergency department rounds. We continue to receive many questions for these rounds and apologize in advance we're not able to answer all of them. We do select major themes from questions received and hope to cover some of them. We also will be doing during these rounds crowdsource and polling questions with results shown in real time so we all have the opportunity to learn together. With that, I'll turn this over to Dr. Bruce Struminger.
Great, thank you, Rick, and welcome everyone, particularly our guest presenters today, and to our panelists, and to the over 400 participants joining. I'm just going to go over a few logistical issues. And first, just want to remind everyone, there is a Q&A function in the lower Zoom bar at the bottom of your Zoom window. Please put your questions and comments regarding today's presentations there. We'll be looking for those and trying to answer any that we are able to. There's a chat function in Zoom, and if you've got technical or IT issues, please put those there. Also, we will be asking you a couple of crowdsourcing questions, open-ended questions, and we'd love you to include your responses in the chat. This session is being recorded and your attendance is consent to be recorded. Thank you for that. The presentations and the recording will be made available through the announcements sent after these rounds. Also, we'll share a link to our website for this series of clinical rounds, and the recordings and the PowerPoint presentations can all be found there within a couple of days. We'll put a link in the chat at the end of the session for continuing medical education and continuing professional development credits. These are offered through the University of New Mexico. They're instant. And after you take 2 minutes to give us your feedback, you'll be able to get instant CPD. We really value your feedback. It's how we evolve and improve these rounds. So please take advantage of that opportunity and share with us your thoughts. So with that, I'm gonna hand the mic over to Sharon Van Arsdale at NETEC to give an update on their webinar series. Sharon.
Thank you so much, Bruce. Hello, everybody. My name is Sharon Van Arsdale. I'm the Program Director for Emory Serious Communicable Diseases Unit. By background, I'm an emergency department nurse. I'm also the program, I oversee the education within the National Emerging Special Pathogen Training and Education Center. And it's been an honor to be able to partner with Project ECHO on these clinical rounds, which then help us understand what webinars, what areas of focus we need to highlight. And so we do have a webinar tomorrow on infection control and prevention strategies. Yesterday, we just completed and recorded a webinar on incident command, really focusing on recovery and resiliency. And so we will be doing a deeper dive into resiliency, realizing that that is it's a hot topic. And then next week, we do have a webinar scheduled on deployment and redeployment of staff. So hopefully you'll be able to join us, and you can visit our website at netec.org.
Great, thank you, Sharon. And now I'm gonna pass the mic to Rosha McCoy with the AAMC. Rosha.
Thank you so much, Bruce. Yes, just to remind everyone of this resource of the Coronavirus Clinical Guidance Repository. It's open access. We continue to update it. We just updated it again today. We're looking more and more into adding guidance around the next phase. And special populations. So, and we also have alignment guidance showing alignment, areas of agreement between institutions and organizations in key areas. So we hope it's helpful. Thank you.
Great, thank you, Rosha. And Rick, back to you for the crowdsourcing questions.
Thanks. There's 2 crowdsourcing questions for these rounds. I saw mental health as one of the resources on the AAMC's repository, and that has been a recurring theme through ever since we started these rounds on March 24th. And so, speaking to that, the first crowdsourced question is, over the past week, what one thing did you do that best supported your mental health? We've had some fascinating novel and not so novel, but some great responses to this question in the past, and would be really good to see what people are doing to help themselves. And then the second one is, what is the leading concern for air medical programs regarding COVID-19? So that one gets pretty specific into leading concern for air medical programs. So if you could go ahead and start working through that chat, or those crowdsourced questions, that would be great. Would be great to see the responses so all of us can learn from each other. If the panelists could please take themselves off mute, and I'm going to start down with in the lower right hand with Dr. Bittinger and go around with name, title, and affiliation, please, Paul.
Paul Bittinger. I am an emergency physician at Mass General Hospital in Boston and director of the Center for Disaster Medicine.
Thanks. Mike?
Hey, good morning. I'm Mike Hastings. I'm the president of the Emergency Nurses Association.
Thank you. Ron?
Ron Kraus. I'm the president-elect of the Emergency Nurses Association.
Thank you. Sandy?
Sandy Schneider, Associate Executive Director for Clinical Affairs at ACEP.
New background, Sandy. I don't know.
I know, I'm getting fancy.
Doug?
Hi, Doug Kupas. I'm a board member for the National Association of EMS Physicians, also an EMS and emergency physician with Geisinger Health System in Pennsylvania.
Thank you. Harry?
I am Harry Seibold. I'm an emergency physician from Helena, Montana, and the past state EMS medical director. I sit on the air medical group for both ACEP and NAMSP, and I'm a past president of the Air Medical Physician Association, ironically during the SARS epidemic many years ago.
Thank you. And Eileen, welcome.
Good morning, welcome. Eileen Fraser, I'm the Executive Director with the Commission on Accreditation and Medical Transport Systems.
Thanks, and I really appreciate the Commission on Accreditation of Medical Transport Systems in not just being here, but helping in shape speakers and help us recruit speakers for these rails. So with that, I'm going to turn this over to our first speaker, Patty Corbett, Director of Patient Safety for Air Methods Corporation. So Patty, please.
Good morning, everybody. I'm going to start my presentation by talking a little bit about how we've developed our system. I think it was about mid-February. Next slide, please. Mid-February, we realized that we were going to have to start looking at transport of COVID patients. So we first put out a safety bulletin, of course, to give our staff some guidance on protection and disinfection. And very quickly, we realized that these patients were going to start coming fast and furious. By the end of February, we stood up our emergency command center and started funneling all information and questions through the emergency operations center, because we felt like that information was going in a million directions and everybody was answering questions differently. So we got everybody on the same page, and the patient safety team stood up. I have 4 teammates that we take call 24/7, and we take intake on every single call. So we've been able to record PPE used, everything about the patient, where the patient was picked up and dropped off, and then we track test results and crew wellness. So we've been doing that since the beginning of March. And very quickly, we realized that we couldn't do this on paper. So our IT department got busy and built us a great system. In ETQ, we track now everything, including each piece of PPE that's worn and what's used on the patient. So we have a lot of data to look back and make decisions with. We then developed process flow charts for all the folks that were in the leadership roles of the organization. So like, for instance, our human resource department, they have a flow chart. So they know how to help our teammates when they need quarantine. And they work very closely with us on giving them guidance after an exposure occurs. So every leader group has a flow chart to follow. And this way we're all operating on the same page. We also had to continually update everything, because as the CDC rolled out more, our charts had to be updated, as well as our bulletins had to go out. The biggest things that we worked on getting out quickly was decontamination procedures. And I can tell you there was a lot of updates on that, because it's not just about decontaminating the stretcher after the transport. It's, everything from the control panel in the helicopter to, the air conditioning system. And we have multiple airframes. So there was quite a few challenges with that. We put out step-by-step guidance for our clinicians, because we felt like that they needed to be able to have a document that they could follow every single time and do it the same way. And I'm happy to say that after doing 1,350 recorded transports, we know we're probably around 1,550, but we have 1,350 in our database, that we haven't had any infections or transport-acquired COVID illnesses. So we're real happy about that. We also established a lot of new clinical procedures, because we had to very quickly orchestrate training on how to switch the ventilator over properly. We realized that in the early part of this development, that our staff were doing a good job of clamping the tube, but somehow forgot to turn the ventilator off or didn't cover the tube as they did it. So we worked through all the kinks and developed step-by-step guidance that really takes our clinicians from start to finish on everything they need to do, all the way through decon of the aircraft and of themselves. And then we developed some running risk assessments. Pilot use of PPE. It's a lot more complicated than you would think, because we use night vision goggles and they have helmets, and they have to be able to talk to the tower through a mask. So there was a lot of a lot of risk that was involved in the pilots using the PPE. We also did a risk assessment on the high-risk age groups because some of our pilots are in that age group. And then one of the bigger ones we had to do was decon of the air conditioning system. And we worked very closely with the aircraft manufacturers and our engineering department to come up with the best way to do this. And then we had staff that actually stepped up and did a lot of training videos. It was amazing, the teamwork that came out of the field with the training videos on transporting patients prone and on deconning the aircraft, and they were high quality videos. So we very quickly got those out and had everybody complete them. Next slide. Some of our top challenges, of course, the number one thing was PPE, the lack of, and getting the right PPE. It took us a long time to get to the point where we could say, we're gonna wear N95s on every single transport, irregardless of what the patient diagnosis is, but we finally got to that point. We got surprised a lot with our trauma patients and stroke patients and cardiac patients that did not have any patient history that led us to believe they were COVID. And after they got to the receiving hospital, we found out something completely different. So we standardized our PPE now for every single transport. Our staff are required to wear an N95 mask. And if the patient is known or suspected COVID, then they have to put on everything, including the gowns or the Tyvek suits and the eye protection they wear. We had to also, with a variety of N95 masks, that was a big challenge, is getting everybody fit tested, because as you know, we had to buy N95 masks from multiple countries, and as they came in and we started distributing, we had to figure out very quickly how to keep people fit tested on what they were using. And we're continuing to look at this. We're looking at some long-term solutions for possibly some reusable products. I know that we just recently got a contract to get 20,000 N95 masks a month. Right now we have enough PPE to wear full PPE on every transport for 8 months, but I can tell you we take inventory of our PPE at every base and at our supply warehouse every single day, so we know where we're at, so we can stay on top of it. We had, like I said, a lot of problems with communication at the beginning because it was rapidly changing. So I think that we felt like it created the most stressful environment for our teammates, because every day something new was coming out about COVID, and the news wasn't necessarily aligning with what the CDC was putting out every time. So we had to very quickly stay on top of information and make sure our staff were educated and understood the importance of paying attention to what was coming out every day, because it was changing so quickly. We had problems with consistent compliance. For instance, we would pick up a patient with no risk of COVID, and we would not, in the beginning, wear anything but a surgical mask. And sometimes with stroke and cardiac patients, we wouldn't even wear a mask. And we'd end up going to the accepting facility and find a whole team of people fully PPE'd and alarmed that we showed up without our PPE on. So we had a lot of challenges to overcome with making sure that we went the extra steps to communicate with both the sending and the receiving to make sure they were all on the same page. We had a lot of problems with COVID testing because there was a lack of testing in a lot of the community hospitals for a long time, and there was a dependency on the radiology results. And so as testing became more available, it seemed like we had a lot better compliance because we knew ahead of time what we were facing. And by going to all full PPE and the N95s on every patient, we felt like we really minimized our risk. We had problems at the base. Our staff live together for 24 hours, and some of the bases are small, and social distancing and wearing masks was a big change for them. We do require that if our staff are within 6 feet of each other, that they have to wear a mask at all times because they're all coming in from different places. Managing stress has been a big issue, and I think that Our leadership team has gone the extra mile to make sure that they're checking in with the staff regularly, and that we're offering them a lot of employee assistance. We had issues with employee travel because we moved people all over the country, and there's some states, like for instance in Alaska, that we had to they changed constantly, where we had to have anybody that went in from out of state couldn't do anything for 14 days, and then we had credentialing problems from state to state, and we had to get everybody an essential travel letter so that they could travel from state to state, because we do have a large number of float team folks that travel all over the country normally. And of course, with flights, reduction in flight availability and things like that, there was a lot of logistical challenges. And then now the most recent one that we're really working on right now is the challenge with PPE and heat exposure. As the summer months have come, we had to do a full risk assessment on the heat exposure, and we're actually testing cooling vests in multiple sites right now, because we're looking at supplying all of our teammates with cooling vests that will cool for up to 4 hours. Next slide. Here's a look at our transports. As you can see, we track everything from our negative tests, the ones that aren't available, our positive tests, and we look at this daily. There is about 200 to 300 transports that have not gone through the COVID intake centers. So we know there are some more out there that happened in the early days that didn't go through our center. But now we feel like we've got intake down to a very organized process, and every transport gets reported through the intake center. Next slide. These are our individuals that are quarantined by discipline. We track that very closely, and our HR team helps us to make sure that the clinicians have the guidance. Every clinician that goes on any transport that has low risk exposure gets low risk exposure guidance from our patient safety team. And then anybody that gets medium risk or quarantine gets guidance from us, both in writing and verbally. So we track these very closely, and these are community acquired illnesses that we've had to quarantine. Next slide. We had to step up to some really unique circumstances in New York, so I wanted to talk about those because I think those brought about some unique challenges. Next slide. On April 7th, we were asked to actually help with evacuation of a hospital in New York that was over capacity. So we actually assembled a team and used the principles of disaster medicine and had a logistics person, an ops person, and a clinical person set the stage for how we were going to do this, because we mobilized 23 aircraft to go in and help evacuate a hospital. We actually put a clinician in the hospital to package the patients, because the emergency department as well as the hospital was completely beyond capacity. And we had patients we were moving that had been in the hospital as far back as March that were still waiting for beds. So we moved them to outlying hospitals that could support their needs. We had to reduce the hospital time. When we first started doing it, we found that it took us 90 minutes to get a patient in and out of the hospital, but by having somebody in there that packaged the patient, got the report, and actually took the patient to the team, that we could reduce the in-hospital time to 20 minutes, which really made us more efficient. We tracked all the data through our logistics coordinator, and our operations coordinator coordinated the aircraft coming in from all over the country and the teams, and made sure that everybody had the supplies and could do the job efficiently. The second event that happened is we had a hospital in New York that early in the evening they notified us that their hospital oxygen system was failing. So again, we had to mobilize a large group of aircraft for patient movement. And we assembled the same type of team, and this time, though, we worked with the New York State Department of Health and the military, because they assisted in these evacuations. And So patients, we're now moving patients from all over the hospital, not just in the emergency department. So there were times when our on-the-ground coordinator would have to move 4 patients just to get to the patient that was being transported. And the hospital was so overrun with patients that we actually engaged the security department to help us to find the patients so that we didn't lose a lot of time just looking for patients. So they escorted us on every transport. These patients were all intubated and ventilated and very high acuity patients. We again deployed the process for disaster medicine. Our flight crews successfully moved all these patients safely to their destination. We used JFK as kind of our response center where all the aircraft met and then went by ground to the hospitals. We taught our staff some key steps to stay focused on oxygenation, ventilation, and perfusion. And our packaging clinician was a godsend. They made sure that there was good communication about the patient's needs ahead of time, that there was ongoing communication with the receiving hospital, and we were highly successful because of the folks that we put on the ground to help with facilitating patients in and out of these hospitals in crisis. Next slide. So some of our wins to me is our emergency operations center. Once it became the single point of communication, we have daily briefings on the phone. There weren't any more mixed messages. Communication seemed to streamline to where we didn't have everybody doing their own thing. It made our risk go down and our staff feel a lot safer in doing these transports. Our CEO put out a letter every single day to the staff, which talked about overall what was going on in the company, shared all the accomplishments. So it was very uplifting and encouraging for the staff. The videos produced by the teammates, we made sure there was a lot of recognition for staff that stepped up and made training videos. And they were really high quality videos and they put a lot of work into it. So we made sure that we encouraged that. Our employee assistance through HR has been phenomenal. They have been great to our teams. And I can tell you that, if our teams get sick and they have to be quarantined, we make sure that they don't go without pay and that they can focus on getting well. I think that throughout all this, the communication in our organization is the best it's ever been. We've seen such great examples of teamwork. And I think in the storm and all the things that we feel like the staff have gone through, they're working better as a team now than ever. Our CEO and senior leadership have held some town hall meetings, which have been real helpful so staff can ask questions. And then our company provided my department with a 24-hour hotline and a single source email, so everything comes through one spot. So I think we've had a lot of positive things that have come out of this, and I can say that we're very proud of the fact that our staff have not had any transport-acquired illnesses. I'll open it up to questions.
Patty, thanks very much for your presentation. One question from any of the panelists? Raise your hand. I got one. Oh, Harry, go.
Patty, did you have any problems with any of your pilots or crew fitting N95s? And did you go to elastomeric or some other type of protection for those folks if they were having trouble getting appropriately fit tested?
The N95s we continue to have problems with because we still have some of them are KN95s and some are US N95s, and sometimes we do have problems with fitting. We take them out to be fit tested. Some of them, no matter how many different masks they tried, we've had problems. So we have a system where they send a picture into the supply chain overnights multiple different masks to the individual and we send them in to be fit tested. But yes, it has been a problem. And I have had some staff tell me that just for comfort, even if they feel like their N95 is working well. Some of them even still to this day put a surgical mask over their N95 mask just to hold it in place so that when they're moving around, it doesn't slip out of place. But yeah, the PPE has been our biggest challenge, and it's an ongoing challenge that we face every day.
Thanks, Patty. Dave, why don't you get your slides up? And while he's doing that, Patty, I got to tell you that this packaging clinician piece, that's masterful. Wish I'd thought about that a long time ago.
Yeah. And the staff that we sent in are phenomenal people, so it made all the difference in the world. They knew how to jump into action and connect all the dots. And that was the main thing, is that no communication was lost, and the patient's care was at the same level that they were getting at the hospital.
Takes handoff to a whole new level. Yeah, thank you. With that, I'm going to turn this over to Dr. Dave Thompson, clinical professor of emergency medicine at East Carolina University and the medical director for Vidant East Care. Dave.
Thanks, Rick. I'm going to talk to you a little bit about Vidant East Care. I'll give you a little background here. We started out in 1985 with a single helicopter. And in the 1990s, we started adding ground ambulances. Currently, we've got 5 helicopter bases and 6 ground ambulance bases. To support those helicopter bases, we have 2 backup aircraft in addition to the 5 regular aircraft. And we have 25 ambulances to support those ground bases, and also for use when we do not have weather that allows us to fly. We have about 120 employees within East Care, communication specialists, EMTs, nurses, and paramedics. I'd like you all to know this gentleman right here is a much younger but no less handsome version of Dr. Rick Hunt. This is the area that we serve in North Carolina, pretty much all of North Carolina east of I-95, including the Outer Banks, vacation areas. We have some of the richest counties in North Carolina, as well as some of the poorest counties in North Carolina. So this population of about 1.4 million people that we serve, there's quite a bit of diversity. Vidant is a 8-hospital system based here in Greenville, North Carolina. We have a tertiary care teaching hospital, Vidant Medical Center. We have several community hospitals, and we also serve several critical access hospitals. At the bottom of this, you can see our various hospitals. These are our COVID admissions by hospital. So the entire system has seen several admissions. And what you'll notice if you look towards the May 11th and that there's a dark blue, that is one of our hospitals that's near a couple of meat processing plants. So they're starting to see quite an uptick in their COVID cases. Vidant East Care, typically we would do about 7,000 ground transports in a year. Typically our helicopters would fly about 3,500 patients. The hospital system itself is about 1,700 licensed beds. At the Vidant Medical Center here in Greenville, we have about 900 beds, and we're the area's only level 1 adult and level 2 trauma center, pediatric trauma center. And we're also the only level 3 NICU in the area. You can see our changes in volume compared to the same time last year. Our ground volume, when you look at this, it looks like we didn't have much of a decrease, but overall we've had about a 10% drop in our ground volume. The air volume substantially dropped off. And I think this just goes along with all the other decrease in healthcare utilization that we've all seen. So what happened initially, almost immediately when we said, yeah, you know what, we're going to fly these patients, we had 3 people resign. They didn't feel that they could be comfortable because of various reasons. Our vendor, who's Metro Aviation, initially said, we can't do this until we do some other things similar to what Patty and Air Methods went through. We got our pilots all fitted with N95 and made sure that they could communicate with that. A lot of our guys had beards. You can see this picture, the before and after photos of many of our folks. About 80% of them shaved right away. We had about 20% who said, no way, no how, not going to do that. We now have 100% that have decided that they want to be clean shaven. The other thing we did was, in addition to our normal verbal shift huddles that happen twice a day, and our regular weekly email huddle note, we added a COVID-specific weekly huddle so that our crews had the up-to-date information that we, as far as we knew. Obviously, as everybody said, this has been quite an evolution. Doing transports, we did some things. We told them that they should run all the fans, the exhaust fans in the ambulances and the air conditioning, and same in the aircraft, but make sure they didn't use any of the recirculation so that basically we were moving air out of the vehicle. For intubated patients, we did the tube clamping and the vent on standby, and we got very disciplined about this pretty early on. We have a couple of paramedics who are also RTs, and they really hammered home the importance of having a very systematic process there. We also made sure that there was a HEPA filter as close as we could possibly put it to the endotracheal tube, so that if there was a breach in the tubing, that there would at least be some filtration. We told outlying hospitals we were not going to fly or we were not going to transport anybody on BiPAP or CPAP if they were known or suspected to have COVID, because we were afraid of mask breaches there. But we found that we were able to use a high flow nasal cannula, 15-liter nasal cannula with a surgical mask, and we felt pretty comfortable about doing that with the ground transports where we've got a little more space. Currently, through the 2nd of June, 19 patients with COVID have been transported by air. Actually, last night we did 2 more. And 57 patients we've transported by ground. Our staffing, despite the fact that we lost 3 people and we did have some openings at that time, we now only have 2 open positions, so we haven't had any problems acquiring staff during this period. We started with some disinfectant sprayers, and now when we have a proven or suspected COVID patient, we have an industrial misting device we can put in the vehicle and turn it on, and it in about 15 minutes will do a disinfectant mist through the vehicle. Normally our turnaround time for our crews is about 15 minutes, so this adds about another 15 minutes to their turnaround. Some of the problems we've all had with PPE, we asked that our crews take their N95 and use it throughout the day, and that they protect the mask a little bit by placing a surgical mask over it. That's been something we've done in the emergency department, in the hospital, and it seems to have worked for the crews. During air transport, we've asked them to, keep their visors down, which we do anyway, but that acts as a shield for them. And the ground transports, we've made sure that they've got face shields with surgical masks so that they can put that over the N95 as well. The crews all have a spare uniform, and typically they've kept them at their base, but we've asked them to keep it with them so that if for some reason they get contaminated, they can change and They can shower if they feel they need to, and we have washers so that they can wash their soiled uniform. We had a scare that we might not have enough ventilator tubing for a while, and so we worked with the respiratory therapy department at the hospital, looking at what we need to do to decontaminate and reuse that tubing. Fortunately, we haven't had that problem. Our supply chain people meet with us 3 times a week as needed, and they've been real good about figuring out ways to get the necessary supplies. We also have a PPE police that comes around the hospital to the various units, including ours, and make sure we have sufficient stuff. We've also found that smaller, more frequent orders to our suppliers has helped. And from a psychological standpoint, we have a really active and very supportive emergency services chaplain. Our hospital has a chaplaincy residency, and she is very supportive of our crews and checks in when they come in. So with that, I'll take any questions.
Dave, one question that just popped up. What kind of disinfectant spray are you using for the ground trucks?
You know, I'll have to, if somebody will send me an email, I'll get back to them, because that's been evolved.
The other one question before I want to do some lightning polling and lightning comments here shortly. But one question while Echo works on getting our polling. One question. Okay, so the decision making about air or ground, how has COVID-19 influenced that decision about whether or not you're going to use the aircraft or a ground unit, or has it at all? Has it made any changes in the decision-making process?
For us, typically, excuse me, for us, when we're going to fly somebody, has been a matter of their acuity, and obviously the weather and those things play a factor. But if we have weather, if somebody is intubated, if they are having a STEMI, acute stroke, those kinds of things that are time sensitive, or they're really sick, we would tend to fly them. Some of these folks that are COVID positive, they're having respiratory difficulties, but they're not yet intubated, that we've had to move, we've done them by ground, just because we can stay a little bit farther away. And for the most part, we figure that we'll save our air resources for the really, really sick and for the scene runs that we still are getting.
Thanks very much. Echo, can you put up the polling questions? And on the polling questions, you know, I saw a comment, you know, this is emergency department rounds, why we're talking about transport. And by the way, emergency department is sort of like, okay, there's a transferring facility, there's a transporting medical unit, air or ground, and there's a receiving facility, and sometimes that's the unit, sometimes. So this is really a team sport. And as we evolve with the pandemic, trying to figure out that team piece is going to be really critical as it continues to evolve with other threats superimposed on COVID-19. So for these questions, realize that there are many disciplines that are part of these rounds. So there are a lot of responses. Sometimes you'll see not applicable and it's not you. But some of these are for transferring, some of these are receiving, some of these are for medical transport. So listen, and truly need you like to click on something so we can all learn from each other. So first question, our organization has transported or received COVID-19 patients by inter-facility air or ground medical transport, just to get a lay of the land. That's a pretty straightforward one, yes or no. Should take you 10 seconds or so, or less. Okay. %6 said no. Huh. Okay. Next. This is another sort of get the lay of the land here, where we are. Okay. Since March 1st, our organization has transferred, transported, or received non-COVID-19 patients by inter-facility air or ground transport. So it's basically inter-facility transport of non-COVID patients. Okay. Okay. 85%. Next. The interfacility transport service or services we use has or have been able to meet demand during COVID-19. Has the interfacility transport service been able to meet demand? Yes, no, or don't know, or not applicable. We got 446 people on this, so we got to get some numbers here. Okay. How about that? 70% said yes. I had no idea what to expect. Next. All right, this is more than 10 seconds because there's a lot of choices here, okay? What one of the following has most enabled our interfacility air or ground transport services to meet the increased demand? Which has most enabled the transport service to meet increased demand? Medical crew configuration changes, medical crew staffing increases, just-in-time education, standard operating procedure changes, access to PPE, patient compartment change, decontamination procedures, communication from leadership, or peer-to-peer support. You only get one. You only get one. The one that's made it so it's most enabled your service to do this. And when I say your service, I mean, you know, you transfer a lot of patients, you receive a lot of patients, or you transport. So the services that you're connected with in some way. I'm betting on one of them. Gonna write it down actually. Okay. I won. Access to PPE. Access to PPE. How about that? Let's see. What else was? Okay. All right. Next. No. Let me see. Yeah. Let me see. Amanda, Amy, don't let it disappear. Let me see. Okay. So we had access to PPE was 31%. And then it looks like communication from leadership and no, SOP changes 10%, communication from leadership 9%. All right. Thank you. This is great. All right, next one. We have transferred, transported, or received transfers of COVID-19 patients whose ventilation was supported by, they were intubated, high flow nasal cannula, CPAP or BiPAP, proned, don't know, or not applicable. So this is multiple choice. So, you know, a ground transport service may, you know, intubate, have transported somebody intubated or prone, and proned, et cetera, et cetera. So multiple choice choices are optional. Okay. A little bit of everything. Okay, next. During the pandemic, we have used a regional medical operations center or equivalent, realizing there's probably 40,000 names for that thing, to distribute patients across our healthcare delivery system. So during the pandemic, we have used a regional medical operations center or its equivalent, whatever the name might be, to distribute patients across our healthcare delivery system. Yes, no, or not applicable. Okay. Wow, kind of interesting. 44% said no, 37% said yes. Next. Since the pandemic, our organization has transferred patients to lower level of care, same level of care, higher level of care, alternate care sites, don't know, or not applicable. And so select all that apply. Since the pandemic, our organization has transferred patients to lower level of care, same level, higher, alternate care sites, don't know, not applicable. I think there's like 2 more quick questions, and then we'll go to the panelists for quick lightning rounds, single comment on what you've heard so far throughout the presentations and the polling. Okay. Wow, that's pretty big distribution. I think I'm surprised by that. I didn't realize it was going to be so broad a distribution. Next. For our organization, since March 1st, the number of interfacility transfers has increased, remained the same, decreased, or don't know. It's pretty straightforward. Okay. Decreased overall. Yeah, 49%. This is the last question coming up. For our organization's response to COVID-19, air and/or ground interfacility transport services have been critical, important, not really a factor, or not applicable. Pretty straightforward. And then for the panelists, if you can go, realize I'm going to start with Eileen with the Commission on Accreditation of Medical and Transport Services, and then go around sort of like the Hollywood Squares block from then on. Okay. Interesting distribution, but majority said critical or important. All right, thank you very much. Okay, Eileen, comments or thoughts on what you saw or heard from our presenters?
Sure. 2 things I'd like to talk about are 2 positive things that I think have come out of this, if we can even say there's any positives. Really, traditionally, competitive programs have a spirit of cooperation that I've never seen before. In fact, there was a program here in the Northwest that was desperate for N95 masks early on, and they were able to trade a case of toilet paper to get the N95 mask with another service. So being creative and innovative, they were able to do that. I also think it's positive that of all the transports that we see that are being done, there's really low numbers of acquired infections from with the staff. The only death I'm aware of was in the Northeast flight paramedic, but it was determined that he had been perhaps exposed from his brother, who died the previous week, unfortunately, from COVID-19. So there really has been low numbers, and I think we're practicing really good techniques. There's a large ground service in the Southeast that had over 4,000 COVID transports and very, very low numbers of ill staff as a result. So I think people are doing a good job. They're sharing all the things they learn, and that's what's so important. That's what's very important about what you're doing here too, Rick.
Thanks, Eileen. And it kind of gives a whole new meaning to the whole like safety concept in medical transport. That's for sure.
Yeah, I mean, I want to echo what Eileen was just saying, and this whole idea of mutual aid. that bartering of equipment or services. I think that is something, we're all in this together. And again, with these competitive healthcare systems, it is quite amazing to see how everybody has really come together. Like here in Atlanta, all of the CEOs of the healthcare systems meet, very frequently to talk about and identify what needs are through the city. So it's really, I think that's been quite amazing. And I think you can see that nationally as you see how many folks have been transferred. When you looked at how many facilities have actually transferred patients, received or sent a patient. So I think that's really amazing.
Thanks. Doug?
Sure, Rick. I think one comment and then a quick question that was spiked by each of the panelists' thoughts. First of all, I think I have seen that transfer centers, and whether it's health system transfer centers or communication centers from air medical groups or both working jointly, have really seemed to step up in this. And I think that communication among the healthcare system transfer centers and the communication centers and all the pre-work that can be done has really helped facilitate making some of these transfers go very smoothly. I'm curious, related to Patty's comments about moving staff from state to state, whether she has seen any ease to that in states that have replica in effect, as opposed to states that do not have the replica compact. And then for Steve, my question there was, we know that in ambulances, the airflow turnover is about 30 times per hour, as opposed to a negative pressure in the hospital, which is like 6 to 12 times per hour in a room exchange of air. I wondered if anybody has done that in a helicopter. What's the air exchange rate?
Anyone?
Doug, you bring up a great question about the helicopter. Initially, there was a lot of concern about airflow through the helicopter. Do you leave the windows open? Do you close them? Those kinds of things. And the blowers are not always the most effective, things like that. I don't know what the airflow is, and maybe that's something, I don't know whether Patty or one of the manufacturers might know.
Yeah, I'm seeing, Dave, I'm seeing a lot of comments about it's airframe dependent. Harry? Yeah.
And another resource that our HIMSS folks might reach out to is NIOSH. They are scientists that know an incredible amount about HVAC, and this is the same question that came up during SARS, and we still haven't been able to answer it. But if we could partner with them, they are the engineer, scientists, that supreme when it comes to airflow and understanding that and measuring that, and that would be a great study for someone to do.
Thanks, Harry. Let's see, Sandy.
Yeah, great program. I think it's interesting that no matter what the group is I'm talking to, the overwhelming issue is PPE. I was talking to the dentist last night, and as they're going back to their office, their biggest concern was PPE. And we're hearing this over and over again. I think it means that the lessons that we've learned in emergency medicine and critical care medicine need to be broadened, and we need to tell them, we need to let more people know. As more people are going back to work, there are more people who are needing PPE in their jobs. So we need to broaden this to our colleagues in other careers.
And for information, and just to amplify what Sandy said, in multiple polls that we've had on these rounds, that comes through. It's just being reinforced over and over again. And just so you know, this is a two-way street with these rounds. That information I've forwarded onto the FEMA Healthcare Resilience Task Force, so they're very aware of what, it works both ways. Yeah. Paul.
I think two things. I think given the high volume of folks with complex ventilator management needs, there was a real emphasis, I think, on the need for critical care transport services more than traditional interfacility EMS with a lot of our patients. And I think it really, underscored the value in this particular use case. And I think I'll also just harken back to the comment about integrating how we work together. Our critical care transport services do a great job of monitoring ICU capacity and volume, but really pulling them in to be active members of our citywide and regional discussions on ICU capacity really helped identify available ICU capacity when we were getting pretty constrained a lot faster. And I hope that will continue, that more than just monitoring, we actually continue to sort of actively discuss between our ED, ICU, and critical care transport partners what capacity is available.
Yeah, well, we talked a lot about air and ground transport. Indeed, I'm hopeful that some of the nurses in the ICUs are listening to this, et cetera, because this, the team piece. Ron.
Yeah, great presentations. I would just echo again what Sandy was mentioning. That's what I wrote down. It just reinforces the fact that access to PPE really drives how and what we do as delivering the care. So great presentation. Way to pivot the care model to the situation. Thank you.
Appreciate that. Mike?
Yeah, thanks. Again, just echo, together we will get through this. That's, what we hear through all these presentations, right? We all have our challenges. It's all coming together to talk about these challenges, how everybody's overcoming them. So that way we can take lessons learned from each places. I did put in the chat for everybody. So ENA has partnered up with ANA and AACN and APNA to do some peer support groups for nursing. So this is free no matter what area you work in. It's a peer support group. So you sign up for those. They're great things to do as well. And then of course I always have to plug the resilience video as well, just because it's great. So end your day with a highlight of a video as well. So it's a great resource for you. So again, ENA is thrilled to be a part of these, and we wish everybody well.
Thanks, Mike. Harry?
Two quick things. A note that these are the same questions that we had when SARS came around 17 years ago, and because that didn't develop into a full pandemic, we never really formalized answers to those things about ventilation, how we transport patients, how we protect ourselves. So I think it's important moving forward that we solidify on our lessons learned. I think NETEC's going to be a great repository of that information because as we know from Ebola, SARS, MERS, we're going to have continued infectious challenges in the future, and this is going to come back around, and if we fail to learn these lessons, we're going to have to pay that price again. The second, both our presenters mentioned the discomfort of wearing PPE. We need also in these environments to recognize the fatigue level that generates, especially in our pilots who are not used to wearing PPE all the time. And if necessary, allow them stand down time so that we don't get into a risk transference issue where their fatigue and protection from one risk, i.e. COVID, not transfer into another risk where they're flying fatigued and in an unsafe environment. I know that our presenters support those things, but it's something we need to get out to all of our providers across the country and think about those issues.
Thanks. Sandy, you had a comment before I go to, before I go to Dave and Patty?
No, I just, building on what Mike said, I just wanted to mention, I put in the chat room, our Train the Trainer for setting up. That's all. I'm sorry.
For the bicep? No. It's like, that's a really important thing. How to take care of each other. No, don't be sorry. It's like, I think it's the core. I think it's the core. Let's see. Dave and then Patty, quick final comment, and then everybody's got to get to their next meeting, including me. So, Dave.
Right, thanks, Rick. I think that we are going to find some lessons that will translate down the road as far as taking care of infectious disease patients. And Harry's right, we've got to make sure that we don't lose this information, and hopefully the folks at NETEC can memorialize it for us. Thanks.
Thanks. Patty? Oh, wait. Dave, I just for the record, that BO-105 aircraft, best ever. Okay, Patty. Oh, you got to go off mute, the mute thing.
Sorry about. Okay, I said the 105 was one of my favorite aircraft too. Is one I started in. I just wanted to say, I think the thing that we're facing right now is as the community starts to relax and people are going back out to eat and going bowling in my state and doing everything, our staff are also letting their guard down. So we're having to be really diligent about really reminding them about PPE, because I'm seeing a spike and people just letting their guard down and not putting that N95 on for every transport and saying, oh, just this is not going to be one, and they get caught a lot of times doing that. So we're really starting to campaign about not letting your guard down, because I think right now that's our biggest challenge we're facing, is that things are getting relaxed in the community, and our staff are getting fatigued and tired of doing it, tired of always being covered up, especially since they have to be covered up at the base too, if they tend to stay in their rooms more.
Patty, thank you. It's a good reminder and a good final comment for sure for these rounds. Bruce, anything before I close?
Just thanks to everyone. Another totally great session. Thanks to our
Yeah.
presenters.
And for everyone, participants, panelists, echo for sure our speakers, our guest from Commission on Accreditation of Medical Transport Services. As we continue with the rounds, because I don't see a need to stop right now, but keep going, because the fatigue thing could really get us down. Realize that the titles and the topics will change with what we're either facing or what the crystal ball says. So just stay tuned and be careful out there, be safe, and take care. Bye.